Hello everyone. My name is Deniz Can Guven. I am an editorial fellow at Journal of Immunotherapy and Precision Oncology. Today we have the privilege of having Dr. Sheth, and he is the author of a recent review published in JIPO, the Contemporary Landscape and Future Directions of Intratumoral Immunotherapy. And before we start, I would like to thank Dr. Sheth for sparing time for this interview, and also I would like to thank him for this great review which was published in JIPO.
It's my pleasure. Thanks so much for having me.
If I may, I will share your review that was published in JIPO, and if you want to summarize it, maybe we could have a quick summary of your paper.
Sure, of course. So the paper summarizes a field of cancer therapy that we have been investigating here at MD Anderson, as well as other sites all around the world. The concept is to try to improve the overall efficacy of systemic immunotherapies. So as I'm sure this audience is very familiar, systemic immunotherapies such as checkpoint inhibitors have really revolutionized the landscape of cancer care, kind of across the whole spectrum of cancer. So many different cancer types, now have approvals for checkpoint therapy. But unfortunately, for many of those cancer types and for many patients, the overall efficacy for systemic therapies needs to be improved. And so, since the release and availability of these checkpoint therapies, we've understood the barriers from a biological perspective that prevent the therapies from working. And so now that we have a better understanding of why these therapies may not work, we've looked to develop combination approaches that can help overcome some of these barriers. And one thing that's become very clear is there's many factors that are within the tumor microenvironment that prevent the immunotherapy from working. So, the concept was developed, well, why don't we just directly deliver some of these therapies into the tumor and into its microenvironment to release those, to decrease those barriers, so that now when the systemic therapies are delivered, those barriers no longer exist. So this is the motivation and the concept behind intratumoral immunotherapy. So again, the goal is to directly deliver therapies into the heart of the tumor that will overcome the barriers for systemic therapies, so that when the systemic therapies are given, they are now more effective. And so this involves many specialties, oncology, of course, but it also involves my specialty, which is interventional radiology. So interventional radiology, plays a common role for cancer patients for local delivery of therapies. Typically, they're therapies that are cytotoxic. So whether it's chemotherapy that we're delivering into the tumor, or radiation, or extremes of temperature, very hot, very cold. Typically, our goal when we put needles or catheters into tumors is to obliterate them. So for us, this is a slightly different concept, because the therapies we're delivering in this intratumoral immunotherapy paradigm are quite different. They're not directly cytotoxic, but they do things to the tumor that make them more amenable to systemic therapies. And so this review summarizes that field of intratumoral immunotherapy, talking about what has been done, what we've learned from that, and how we can use that knowledge to think about ways to do this in the future.
Thank you very much for this great summary and also great introduction. So I would like to discuss several questions which I previously prepared regarding your article and also the field in general. First of all, I would like to start with this question. Besides the T-VEC therapy in melanoma, do you use intratumoral immunotherapy in your clinical practice outside of clinical trials?
Right. So currently, the only approved intratumoral immunotherapy is T-VEC, like you said. So our practice is on the clinical side, on the clinical approved standard of care side, is all T-VEC. And then the other patients that we treat with intratumoral immunotherapy are all in the context of clinical trials.
So thank you very much. So I would like to ask another question, which is also discussed in your article. Actually, I would like to ask what are the main challenges associated with the use of intratumoral immunotherapy in your daily practice?
Yeah, it's a great question. And so this has been a very important point for us to learn as we've been doing these trials. So, at this point, we've done about 2,000 of these procedures. And so in the past 5 years, we've gained a fair amount of knowledge, both in terms of things that work, but more importantly, in things that don't work. And so, understanding how this might fail will help guide for the future. So what do I mean by that? So when we think about the tumor and its environment, we think a lot about the microenvironment. And so we think about, the immune phenotype. Is it hot or is it cold? Is it an immune desert? So people talk about that a lot. That's, of course, important in terms of barriers for systemic immunotherapy. But besides the biological properties of the tumor, we've also learned that the physical properties of the tumor are also important, especially for these therapies. So, this is not a new concept. We've known that physical barriers in tumors prevent systemic drugs from getting there. And so this, people have been talking about these physical barriers for a long time. And you might think that just because you put a needle into the tumor and directly deliver the drug, that these barriers aren't important, or they don't prevent the delivery from being accurate. But unfortunately, that's not the case. Unfortunately, these physical barriers still are a big problem, even when you put a needle into the tumor and directly deliver the drug. So it's made us think a lot more about these physical barriers, not just for systemic delivery, but also for direct intratumoral delivery, and what we can do to overcome them. So as you can see in that figure 2, and one very straightforward thing that we've done is just use different designs for our needles. So our typical needle just is a single needle with one little hole at the end, and you inject it. But there's ways to do it better. So the images below show some other needle designs that again, they're on the shelf, that are easily available, that we can do. So one of them like that has multiple tines that can be spread into the tumor. Others have multiple holes, so it's like a water sprinkler that will spray the drug into the tumor. So we've seen in both the preclinical setting and in the clinical setting that these different needle designs lead to better drug delivery into the tumor because they can account for some of these physical properties. And likewise, we can do the delivery not just with a needle, but also through the blood vessel into the tumor. And so likewise, there are other designs for these catheters that we put inside blood vessels that can again improve the delivery and the drug penetration into the tumor, with these different designs. And so the kind of appreciation for these physical properties and the use of straightforward technical improvements to deliver the drugs has been something that has been quite important for us to learn and to perform. And that's completely independent of the drug itself, in terms of the drug and its biology. So holding all of that constant and not changing that, just improving the delivery of the drug, we believe will lead to improvements in the overall effectiveness of the therapy.
So thank you very much for your great answer. My last question is that what are the most promising ongoing developments in the interventional radiology fields which could help us apply the intratumoral immunotherapy more effectively in the future?
Yeah, it's a great question too. So we're very optimistic about the ways that we in interventional radiology can help with the systemic immunotherapy efficacy. So, from a very broad sense, interventional radiology, we focus on drug delivery, and we can deliver, to some extent, just about anything, just about anywhere in the body. And so I think that gives oncologists and the rest of the field a lot of versatility in terms of what can be done and to ideally optimize efficacy and minimize toxicity. And so, when we think about what we can do, in addition to these immunotherapies that we can deliver, we have other approaches that we can take. So, for example, delivering heat or delivering cold or delivering radiation that I think can also help with not just the biological barriers, but also the physical barriers. So, there's very long-standing data to show that things like hyperthermia can change some of the physical properties of a tumor that improve drug penetration. So things like that can be combined with intratumoral immunotherapy and, of course, with systemic therapies to help overcome both biologic and physical barriers to overall improve the efficacy of these systemic therapies. So, I think the versatility of our specialty is something that, we can try to take advantage of, especially when we have a strong understanding of what are the problems that are impacting the overall efficacy of the systemic therapies.
Thank you very much for your for this great answer. Also, it was very insightful. Dr. Sheth, do you have anything to add?
No, I appreciate your the opportunity to share some of these thoughts, and like I said, I'm very hopeful that these combination approaches using these minimally invasive procedures will open new therapeutic potential for systemic therapies.
Thank you very much for your time and also being here with us. You can follow JIPO on YouTube, Twitter, and LinkedIn. And have a nice day.
Great, thanks so much.